Ladies and gentlemen, good afternoon. Hello again. As we all discuss today, vascular access is some Achilles heel of hemodialysis, and it helps to save lives and so on, but sometimes it may even harm. So let me open some of these topics together with you. For hemodialysis, we need regular entry to the bloodstream with a flow volume about 400 ml per minute, twice up to 7 times per week. It depends on the regime. If we look at the physiological resting flow volume in brachial artery, according to our data, it is something around 100 ml per minute. And after the creation of vascular access, it rises up to 1000 or up to 1500 ml per minute, which is considerable change, and which represents up to 25% of normal resting cardiac output. So this is why it must have some influence on the heart and on the systemic hemodynamics, but also on the local hemodynamics. So if we speak about high flow vascular access, we should first define what's high flow, what's low flow. There is no strict definition. Nevertheless, mostly low flow access is considered to be less than 600 ml per minute, or clinical definition is that it is inadequate dialysis dose at usual flow volume in the blood pump. High flow access is something more than 1500 ml per minute, or a state with clinical problems. The question could be, what's better, to have low flow or high flow access? There are some advantages and disadvantages of both, because high access flow is good for the longer access patency. There is practically no recirculation. Nevertheless, it could lead to hand ischemia, heart failure, pulmonary hypertension. It increases venous pressure. On the contrary, low access flow is good for the heart, probably. It is not forced, so we rather feel that it is more physiological. However, low flow accesses generally have shorter patency and higher risk of recirculation. So, if the systemic consequences of access creation are as follows. The access creation leads to decrease of peripheral or even systemic vascular resistance. That means decrease of afterload, increase of preload, which drive the increase of cardiac output and the development of hyperkinetic circulation. It's like jogging. But all 24 hours per day, sorry. The pathological consequences include heart failure, pulmonary hypertension, and hand ischemia. I am a cardiologist rather than nephrologist, so I'm more familiar with heart failure, which is defined as a state when the heart is not able to maintain to cover the tissue requirements of oxygen and nutrient supply, or it is able to do it at the price of higher filling pressure. What does it mean, the higher filling pressure of the left ventricle? It means that there is higher pressure in the left atrium and therefore also in the pulmonary veins, and this is why the patients develop shortness of breath. Shortness of breath is one of the most common symptoms. The others include fatigueness, edemas, hypotension, or some others. In the dialysis population, we can meet two types of heart failure. It could be hyperkinetic heart failure, which is rare, and it is characterized by high cardiac output, or even very high, up to 10 liters per minute. And much more common is the classic congestive heart failure, when the cardiac output is relatively or absolutely low. We have some data, not based on a large series because it's a rare condition, but hyperkinetic heart failure is characterized by the symptoms: high BNP, high cardiac output, tachycardia, and the vascular access flow volume is usually high. It means at least 1500 or so, and the blood pressure is normal or low. Eric Chemla from London performed a study, studied a series of 17 patients suffering from symptomatic hyperkinetic heart failure, performed surgical bending of the AV access, and you can see that the flow volume decreased from 3 liters to 1 liter per minute, which was mirrored by significant decrease also of the cardiac output, and most importantly, the symptoms disappeared. The hemodialysis patients have also other mechanisms of hyperkinetic circulation. One is the volume or water overload between hemodialysis. The second is anemia, sometimes even inflammation. Therefore, we can conclude that the heart must work harder in dialysis patients, but unfortunately it is usually not healthy. And it is why these patients develop frequently heart failure. So who is at risk of high access flow? These are patients with proximal, it means brachial artery-based AV access, patients having too large anastomosis. Higher access flow is more usual in younger patients, but it could also develop after some time thanks to the remodeling of the feeding artery, or it could increase considerably after PTA. The classic or congestive heart failure we know from the general population, where it could be based on coronary artery disease, valvular heart disease, and so on, also occurs in end-stage renal disease patients. And it is characterized by symptoms, high BNP, and inadequately low heart function or cardiac output. In this case, we have to consider that the cardiac output we measure, for example, by echocardiography, is the sum of the cardiac output used for the tissue perfusion and the vascular access flow volume. So heart failure occurs in about 1/3 of new end-stage renal disease patients in USA, and these patients have significantly shorter survival, and there are various reasons such as enlargement and systolic dysfunction of the left ventricle, valvular calcification of the mitral valve and tricuspid valve with inadequate opening and with regurgitations and so on. There are many factors which influence the development of heart failure. It is also not only volume overload, but also pressure overload. It is frequent coronary artery disease, arterial hypertension, valvular disease, systemic calcifications of the arteries with increased arterial or aortic stiffness, arrhythmias, but also vascular access. flow volume, but unfortunately we do not know much about the influence of vascular access flow volume. We know that left ventricular hypertrophy is a common state in end-stage renal disease patients, and we think that this is the pathway to left ventricular hypertrophy, and the volume overload has probably the most important role, but it has been shown by animal experiments that also creating an AV fistula creation of AV fistula could lead to the development of left ventricular hypertrophy. So the effects of AVF creation on the heart include increased cardiac output, usually increased or temporarily increased left ventricular ejection fraction. On the contrary, plasma renin activity decreases and the left ventricular diastolic function worsens after the creation of dialysis access. We performed a study of, we studied the BNP, B-type natriuretic peptide levels before access creation and 6 weeks after. You can see that there had, say, normal values of flow volume, but there was significant increase of BNP after creation of vascular access, and moreover, the BNP levels correlated with access flow volume. I like this chart showing the time development of one single patient who was extensively studied in our hospital, and it's a lady. She was about 50 years old at the time when she needed vascular access, and she had also echocardiography and so on. So you can see that the blue curve means the access flow volume together with the increase, spontaneous increase of flow volume. There was increase of BNP and also increase of left ventricular diastolic diameter. The lady developed symptoms, therefore surgical bending of the access was indicated, and again the flow volume decreased as well as BNP and left ventricular diastolic diameter. So it seems that the changes we observe are reversible, or at least to some extent reversible. Pulmonary hypertension means the increase of mean pulmonary artery pressure above 25 millimeters of mercury at rest. It's very common in end-stage renal disease patients, and it is associated also with a higher mortality. And there could be various symptoms of pulmonary hypertension, and but according to our experience, most of the patients suffer from some fatigueness, some dyspnea, tiredness, and so on. AV fistula is linked to pulmonary artery pressure, although it is not the only reason of pulmonary hypertension. It is linked by the increase of cardiac output, because if you remember from physiology, pulmonary vascular resistance is related also to cardiac output, and other factors could include some thromboembolism after thrombolysis of a vascular access. It could be diagnosed non-invasively by echocardiography if the patient has tricuspid regurgitation, because the velocity of the regurgitation represents the pressure change or difference between the right ventricle and right atrium. So if you add the central venous pressure you get the systolic velocity, systolic blood pressure in the pulmonary artery. From the practical point of view, the question could be: is the AVF looks big? Then we should always measure flow volume if we do not do it regularly, and especially we should do it in patients having some symptoms such as fatigueness, shortness of breath, peripheral edema. Unfortunately, all these symptoms are also symptoms of pure water overload, and must not definitely mean pulmonary hypertension or heart failure. Therefore, we should do also some other examinations, and then these methods could help us to distinguish between pure overhydration, heart failure, or pulmonary hypertension. If this is present, then please consult a cardiologist. Finally, hand ischemia it could be a consequence of high flow access, and very shortly, its incidence is up to 8 or say 10% of our patients. If we include also the milder stages, the diagnosis is based on diminished pulsation at radial and ulnar arteries. If the patient suffers from acute pain, hand pain, and then compression of the outflow vein could help him or her. There could be, or typical feature is the decreased systolic blood pressure at the fingers, and we should keep in mind that, of course, if the patient suffers from general or systemic hypotension, then he or she must have also low pressure at the fingers, because sometimes some patients are sent to our center because of hand pain, but the only reason is that they have too low dry weight. Digital pressure measurement could be done by various techniques, and this is how we do it, very simply and very and not inexpensively. And we should differentiate between two large modalities, which is true steel to white anastomosis. This is linked to high flow vascular access, or it could be due to problems of inflow, and ultrasound is a good choice how to differentiate between these two etiologies. So we can measure the flow volume. If it is more or less than 1,000 or 1,500 mL per minute, then we consider narrowing and so on, which was already discussed. I only would like to mention that the so-called steel phenomenon, which means reversal of blood flow in the distal part of radial artery, is normal in dialysis patients because of very low vascular resistance in the hand thanks to AV fistula, and it must not be used. It is not the steel syndrome, which is another term for hand ischemia. Ladies and gentlemen, please let me conclude that hemodialysis vascular access can lead to considerable hemodynamic changes, and they are mostly well tolerated in the majority of patients. We have no data regarding their influence on mortality up to now. In some subjects, it is associated with local and or systemic pathological consequences we have discussed. And thank you for your attention, and see you next year.
I think so. It's very lucid presentation. related to hemodynamic consequences of this. Do you think that before going for all these AV vascular cannulations, who are those patients who are more prone to have hand ischemic problems? So practically getting anything workout done early to prevent this hand ischemia problem.
If the patient has hand ischemia prior to?
Yeah.
If the patient suffers from hand ischemia prior to access creation, we usually recommend creation on the other extremity if it is possible, or anything else, because if the patient suffers from hand ischemia, although without or already without vascular access, there is, according to my opinion, up to 100%, we can be sure that it will worsen.
One Malik, thank you very much for the excellent talk. Just one question, and that is, in some people, especially the younger people with forearm fistulas, you find high flow rates that come on rather quickly, and then you close them because you know the alternative, and then you often have to start, you make a fistula on the other hand, and sometimes even that goes into a high flow state. It's not a surgical issue here. Do you think there's some, some people more predisposed to this vascular modeling or something else that predisposes them to these high flow states?
Higher flow volume is more common in younger people, and the question is if to do with it or not to do anything if the patient doesn't suffer from any symptoms. What we do is if we catch someone with high flow access, then we ask for symptoms and perform echocardiography. If echocardiography is with good results and the patient suffers from no symptoms, then we just follow up him or her without any intervention.
Dr. Malik, taking the topic a bit further, following a successful kidney transplant surgery, most of us do not recommend ligation of an AV fistula unless patient has severe symptoms that is cosmetic. Should we routinely recommend closure of these fistulas after transplant if everything is going good?
Well, it's another topic, and there are data that transplant patients do better if the fistula is ligated. Nevertheless, you never know how will develop the function, the graft, the kidney graft function after the transplantation. So I think it must be. There must be an individual approach according to creatinine and data and echocardiography and actual access flow and so on.
Dr. N.P. Singh.
Very nice talk, sir. You said you are more of a cardiologist than nephrologist. I am a physician and more of a nephrologist. So I will take AV fistula as a nephroprotective. And I would say that if done earlier in a select group of people, you did not discuss the hemodynamics of the changes in kidney, doing a pre-ischemic reconditioning and protecting or retarding the progression of kidney disease. So what are your comments on that? And after that presentation in 2015, we've been observing, and I am now taking that article as a clue and trying to tell my patients to get that AV fistula done earlier. So you might, and some of them have really benefited. Just an observation study. What are your comments?
Thank you. I know there is a study which observed decreased or slower decrease of renal function after AV fistula creation. It's true. As a cardiologist, I could think that it could help, especially in very hypertensive or with patients with uncontrolled hypertension, because it is a non-pharmacological measure how to decrease the blood pressure. But we have to balance between the pressure and volume overload, and it's a challenge sometimes.
So here the physiology is ischemic preconditioning.
Yeah.
You create a ischemia.
Many patients of end-stage renal failure, they are having poor ejection fraction. So what is the cutoff value of ejection fraction prior to creation of AV fistula? Your comment.
Yeah, this is important and frequent question. According to my opinion, there is no known cutoff value of ejection fraction. This is because of many reasons, and I can tell only some of them. First, ejection fraction is a dynamic measure which depends on blood pressure, which depends on coronary artery disease, on water overhydration, and all these things. Second, it could be reversible if it is decreased due to stunning, such as hemodialysis-induced stunning or ischemic stunning. Third, if the left ventricle is enlarged, then lower ejection fraction could maintain the same cardiac output or stroke volume and cardiac output as normal ejection fraction of smaller left ventricle. So I think that more important is to speak with the patients regarding their problems with shortness of breath and all these things. Maybe to measure BNP after the optimal hemodialysis setting and so on, and then consider. But I won't say any clear exact value. Sorry.
Okay. Now, can somebody take care of the microphone, please? Yeah.
Yes, we have had patients with very low ejection fraction who did well after access creation and no problems.